I'm glad that I'm here talking to you guys about the prosthetic complications of dental implants. This presentation is a part of a longer version of prosthetic complications. We will go through as much as we can, and I have decided to go for explaining a little bit more on the more common or more kind of trouble-making problems that we face on our day-to-day practice. And I will provide some background information about that. I have tried so hard not to just repeat the cliches, and I have tried to give it a more pragmatic way of explanations. And without any delay, let's go to the first part, which is related to the emergence profile. With the emergence profile, most probably you guys know that if you restore an implant, you would like to restore the implant, you have the platform of the implant, and then there is the coronal part of the crown, and the transition from the platform of your implant to the coronal part, to the gingival margin, is considered the emergence profile. So when we are talking about the emergence profile, the development of the emergence profile would involve basically number one, the size of the implant platform. So we always talk about the emergence profile, but we don't pay attention to the size of the implant. If we have a large implant, of course, developing a better emergence profile will be easier. So that's number one. Number two is the depth of the platform, implant platform inside the bone. That's very important too, and we will see why both the vertical and the horizontal components are so important. So to have a nice and proper emergence profile, the restorative dentist will be relying on the ability of the surgeon to place the implant properly in the right place so the technician can develop the emergence profile in a better way. Now, the state of problem is that when we are restoring our implants, the crown size is always the same. You can't make smaller crown, let's say that, especially for the aesthetics. So the size of the crown is always the same. However, most of the time we don't have the luxury of placing large implants, wide implants, because we don't have enough bone in most cases. And if we place larger implant to have a prosthetically driven prosthesis, we are going to be risking losing bone around our implant, because then the size or the amount of the bone around our implant is going to be very limited. So it's like a balance. You cannot ignore the prosthetic part, which is the emergence profile. You have to be careful with that. You can place very small implants, but at the same time, if you want to place large implants, then you run out of bone, and there is a better chance that you lose some bone. The patient would have the bone loss over time. So in this picture, you can compare the two, and you can see that at the CJ, or just at the platform, in this picture, you can see that there is a difference. You have this size of implant, however, the size of the tooth is different, and it's larger, and this causes some problems. Now, let's see what are the rules and principles when it comes to the emergence profile. Generally speaking, when we are placing our implant, as I said, there are two factors that are important in placing the implant. Number one is the size of the implant, size of the platform. The second one is the location of the platform. Now, if you take a look at this picture, you will see that the implant has been placed and it has the right size. However, now if you want to place a smaller implant, you have to place it a little bit deeper. That's the only way. Now, if a patient does not have enough bone, and if the surgeon is placing the smaller implant deeper, as you can see, this triangle actually is a golden triangle. The size of the implant, the size of the platform can be smaller as you place the implant a little bit deeper. And when you compare the two, you will see that the larger size implant, as you can see here, should be placed somewhere around here. And then the smaller size implant can be placed here. It's mostly because from this platform, or actually here, from this platform all the way to here, you have the opportunity to develop your emergence profile. Now with this background, you will see that, well, that's not the, so here is the lines, as you can see. If you are going to place the implant, or the surgeon is going to place the implant at the level of the bone, very shallow, then the implant has to be wide body. If now I want to go a little bit forward and talk about the annulation that we're talking about this part. Don't forget that when you look at the annulation of the
placed superficially or at the level of the
implant,
crest,
they can affect our emergence profile.
Soft tissue
most of the time, when you have the implant placed in an angle situation where the line angle and the long axis of the implant is not exactly the way that we want, that can cause a problem with the emergence profile. And in here, again, by placing an implant deeper, the dental technician is going to have the opportunity to provide the acceptable emergence profile. So when you look at the comparison of different levels of implant, you can see in this picture that with the implant, when it is deeper, the technician will have a better option to provide the emergence profile, while here the technician has to form the platform so quickly and bringing the transition line from the platform to the level of the abutment so quickly. In these cases, we are going to have quite a bit of problem, and now you can see in these pictures where you have the implants very superficially placed. The size of the implant is supposed to be large. The emergence profile is not going to be acceptable, and then as a result, you are going to get quite a bit of food impaction, debris going everywhere, and with having such a prosthesis, definitely you're going to have a lot of bone loss. So what we have to remember is that emergence profile is an important part of our treatment planning that can cause a lot of prosthetic issues, both prosthetic and biological problems, complications for us. And planning for an acceptable emergence profile will start from the time that the implant is going to be placed. So communication with the surgeon and the restorative dentist is extremely important. And I think it's very important to know that a surgeon would look at the treatment in a different way, and a restorative dentist needs to communicate with the surgeon to make sure that the post-insertion problems are not going to be happening. Now, related to the emergence profile, the other problem is the misplacement or unacceptable placement of the implant. You have an implant where it's not in the right place, and in these cases, especially in this case, you will see that, well, the implant has been placed very close. Now, of course, the emergence profile here is not going to be acceptable. So from here, you're going to have a difficult time to form the emergence profile, almost no proper emergence profile. And at the same time, you're going to have quite a bit of room here and also under this pontic-like part of the crown. You will be praying that, well, this implant will fail. That would be definitely that would be a better option than having this one in this place. So what should we do? Let's say that the implant is in. Yes. You can see?
Yeah.
If I can
We only see half the slide.
Yeah. Okay. Yes. Is it better?
Yeah.
Better?
Yeah, okay. Thank you.
Okay, so let's say that we have an implant placed like that. What can be done? In most cases, when we have these sort of misplaced implants, we are going to have both biological complications, including the pre-implantitis, and the mechanical problems, which is the screw loosening, the screw fractures. And it's mostly because of the cantilever that you have. You are going to have food getting stuck around here and also between this tooth and the other one. And of course, because of the cantilever, the screw is going to get loose, fractured. What is the solution? In my own cases, I would always prefer to have, when I have something like this, either it is a pontic that I have, or it's just an extended part of the crown sitting there, I would prefer to have an ovate pontic, an ovate form pontic. Making sure that I have a very close contact with a convex surface, with the gingival surface. Extremely important. In many cases, we need to make the sacrifice and restore implants with unacceptable positions, in a way that we don't have the contact properly between them. Number one thing that you always have to do is recontouring. We don't have the picture of that, but recontouring the adjacent teeth, extremely important, just to make sure that your technician can provide a nice contact without having a black triangle, although it's not visually a problem in posterior cases, but definitely the patient is going to have a lot of problems with debris and food getting stuck in there. So it's better to recontour the mesial, distal, adjacent teeth. That's number one. I always do that. Do this also in your RPD cases. That's extremely important too. When you have an RPD cases, don't be afraid of recontouring the abutment teeth. It's exactly the same concept here. In RPD cases, we need to develop the right guiding plane. In these cases, we need to develop the right contact. So, recontouring of the adjacent teeth. Number two, if you have to make a pontic, if you have to have a crown like the other one that I showed you with a long cantilever side placed off center, it's always better to start, in this case, to start with a temporary. With a temporary, you start pushing against the tissue. Sometimes I use the electrosurgery. I'm pretty sure that you have used that too. You use this electrosurgery to make a crater area, an area of depression. And then you make your temporary, you add composite to the pontic, you make the ovate pontic in the area, and then after a while you're going to have a nice pontic area, as you can see here. It was not like this here. Now you have a pontic area here. Now that you have a pontic area, you're going to do your impression taking with the emergence profile. We know that after the emergence profile is provided, you place the impression coping and you use the flow ball to capture the emergence profile. So this is the emergence profile of this implant. And now you are going to provide a very nice foundation for your technician to make a very nice prosthesis where you have a nice emergence profile, and under this pontic there is no way that anything can go in. One thing that you have to remember is that, and I think there's a misunderstanding about it. Under any pontic, if you have a close contact with the tissue, there will be, although it's weak, but there will be a weak hemidysnosal connection between the surface of the either porcelain or metal and the gingival tissue. In a way that when you remove this pontic, you will see that the tissue is quite red. This is because of the very weak biological contact between the two, and there is some sort of attachment. This attachment is important. So as much as possible, it's better to be able to develop a convex surface which is in direct contact with the base of the tissue. And in these cases where you have a pontic or cantilever type of crown, it's better to develop this sort of connection between the gingiva and the pontic. Okay, let's move on.
What would
Yes.
be your hygiene instruction for the patient in this case?
Do not clean under the pontic, because once you start cleaning there won't be any biological connection between the two.
And what are you getting from this connection?
Pardon me?
What are the benefits of having this biological connection?
The benefit is that everything is sealed. But the catch is that it has to be convex. Cannot be a concave type of connection, a concave type of surface. You have to make sure that you have this ovate pontic, not a saddle, not a concave connection. Otherwise, you're going to have a lot of problems. But as long as it's ovate, it's going to be working very nicely.
So it's for the health of soft tissue around it.
That's right, because nothing
Not
can go
for
wrong.
any support.
No, absolutely not. It's just for the tight seal, so nothing can go underneath, and you're not going to have anything around the margin, the interproximal area. And strangely, around the embrasures, you're going to have the eruption of the papilla, which is a wonderful thing. Okay.
How long do you leave it separate for?
Pardon me?
How long do you leave it separate for?
How long? Well, it depends how long, how young the patient is, but usually somewhere around 3 months, you are going to get quite a bit of nice ovate pontic area ready to go.
So the tissue will keratinize, there will be no red inflamed.
It will be red area. You want that red. You want that red.
So
That's
actually, I think it does give some support to cantilever forming.
You're not counting on that, especially with implants. You're not counting on that at all.
Strictly for cosmetic reasons, plus.
That's for the biological reason, not for the mechanical reasons. Okay, so if you don't mind, let's move on. Now let's go to the next one, which is somehow related, and that's about the loss of interproximal papilla. That's a very important problem. Usually, in these cases, if the patient has a high smile line, it will be very difficult, sometimes disastrous. And in most cases, based on Dennis Tarnow's, probably you have heard that, Dennis Tarnow's study, which is not a very scientific study, but it's practical. Based on Dennis Tarnow's study, you would say that from the crest of the bone to the contact of the two crowns, if we have 5 millimeters, there is a good chance that the papilla is going to grow and you're going to have a nice pink architecture. We have to remember that when we are talking about implant in the aesthetic zone, it's not about white, it's about white and pink. So in most cases, we have to be careful about what we are going to explain to our patients and what they would expect from the treatment. And to do that, we have to be able to predict what is going to happen. And that 5 millimeter rule can be considered a practical method with a little bit of salt and pepper we have to take it, but it is a good practical guideline. Then when we talk about these cases, we have to remember that there is a big difference between single implant that we're placing versus 2 implants. It's very challenging when we have 2 centrals missing, mostly because the bone between them is gone and the scallop form is not going to be there anymore. And as Dennis Tarnow was always saying, everyone can show the single implant cases. It works nicely, they know that it works, no problem, it's pretty. 2 implants is sometimes next to impossible to do a good job with the triangle, the black triangle that sometimes you get. So now that we know that single implants are easier to restore than 2 implants on the central because of the loss of the bone, the other one is the problems with the lateral incisor, with the central incisors. Now, it's always easier to restore the laterals. Why? Because no one notices the triangle between lateral and the central. And your lab technician can easily hide that problem. It's mostly because the connection is around a curve. So visually, people around, or even the patient himself or herself, is not going to see the area of triangle. At the same time, well, centrals are always right to the eyes of the people around them, and they can see that. So there's a difference between central teeth to be replaced, central incisors to be replaced, versus the lateral incisors to be replaced, and you have to be mindful that well, with the central you have a more difficult job. Now that we talked about the single versus 2 implant replacement, you have to remember that it's not always easy restoring single implants. If you have this sort of bad neighbors adjacent to the teeth, adjacent to the missing tooth, of course the final result is not going to be as nice. Mostly, well, you have lost some bone, and now the space from, or the distance from the crest of the bone to the contact of the adjacent teeth is going to be more than 5 millimeters in interproximal contact. It will be more than 5 millimeters, so you're going to have a difficult time to cover that. And in these sort of cases, and also in more difficult cases where you have lost some space, you will be relying on the pink structure created by your lab technicians or technician friends. Without them, well, it will be almost impossible in many cases to restore those defect areas, and well, of course, you have to rely on the smile line of the patients too. So altogether, I think to avoid these sort of complications, prognosis is very important. You have to evaluate the smile line of the patient, the amount of bone lost, the amount of which tooth is missing. Is it 2 implant, 1 implant, central, lateral, the neighbors are good or bad, and then based on that you can explain to the patient what to expect. Okay, so let's go to the next part, which is the abutment, the show-through phenomenon. In many cases, we have to accept that the titanium abutments can cause a lot of problems, either by after the shrinkage of the tissue in the bone, then you're going to have the exposure of metal, or sometimes it's just a reflection of the metal, as you can see here, which is the show-through phenomenon. And what can we do in these cases? Okay, so for these cases, we have to consider the alternatives to titanium abutments, but when should we consider the alternatives? One of the factors that will help us to avoid this complication is the gingival biotype. If the gingival biotype of the patient, or phenotype as some people would say, if the gingival biotype is thin, well, of course we're going to have a difficult time to cover the gray shadow. However, if the thickness of the tissue is beyond certain level, you can actually say that, well, the tissue is not going to reflect the shade, the gray shade of titanium. Jung did a very nice study to see, well, practically how much of thickness is enough. Based on their result, they were saying that if it is 3 millimeters or more of thickness, as you can see here, 3 millimeters from here to here, if you have 3 millimeters of thickness here, the tissue is not going to let the gray shade to be reflected. However, if it's about 2 to 3 millimeters, you're going to have this sort of discoloration of the pink, and then below 2, definitely it will look gray, and it's not going to be acceptable. So, simply you can beforehand, in many cases, you can just check patient's biotype and know that if you are going to have a difficult time or it's going to be an acceptable situation. And in this case, well, I didn't have a difficult time, mostly because the patient had a thick biotype. So as you can see, this is an implant, it's not showing anything. And of course, as you can see, because the adjacent teeth are there, nice pink is there. However, as you can see between these 2 implants, you can see that it's very little, and the lab technician has extended the contact all the way up there, and no one would notice that because everyone is going to notice these 2 veneers, and they're not going to see the problem here. So biotype is extremely important, and it's going to be more predictable when you have a thicker biotype. Now, if you want to consider an alternative, what type of alternative? What kind of alternatives would be available for us? Number 1 is opaque titanium abutment. Some lab technicians would do that, some would not, because the opaque itself is a little bit unpredictable. It can flake, it can be broken, causing biological problems after. So that is one of the ways, and we have to remember that having a chemical bond between the titanium and porcelain is quite unpredictable. Nowadays we're better at developing this, but in most cases it's very difficult to have a good bond. So if you have an opaque titanium abutment, there is a chance that this opaque can actually break, and then food and bacterial trap, and of course it will show a little bit more. The other option is gold hue titanium abutment. Have you ever used this gold hue? I'm not sure if you have used that or not. It's a nitrate surface. Atlantis would do that. The problem with these ones that I had, well, of course, the warm hue of the gold is not going to be as gray as titanium. You know that, it's quite obvious. The problem is that this coating that they put, it's a nitrate coating that they put. This nitrate coating can actually somehow be fading away, and after a while it's not going to be as gold as you can see. Even with touching with your fingers, after a while the cover, the coating is going to be somehow degrading, and it becomes more and more dull and kind of gray. So long-term, there's no long-term studies on them, but there is a chance that this hue, this gold hue, would fade away, and then after that you're going to have again the gray problem. The other option is zirconia abutment. Nowadays it's very common using zirconia. We're getting better and better and better with zirconia, and of course we're not going to have much problem with zirconia. However, with zirconia there are a couple of different options that we have to pay attention. We have to make sure that we are using the zirconia abutments properly, and to know which type of zirconia abutment would be the best option. Irene Saylor, one of my favorite scholars from Switzerland, she has run this elegant study, RCT, very well designed, comparing one-piece zirconia abutments versus two-piece zirconia abutments. As you can see here, you can see that this one has a metal base, the other one has all zirconia. In her study, she showed that two-piece zirconia abutments, which are sometimes we call them hybrid, two-piece zirconia abutments would show superior strength as compared to one-piece zirconia abutment. And most of the time, the fracture connection, the connection between the abutment and the implant would fracture, and that was one of the main observations that Dr. Saylor could record and report. And to explain the matter a little bit better, as you can see here, well, this is a very nice, pretty zirconia. However, the connection is the weak link, and it's very dangerous to have this connection versus the other one. And this is called the full zirconia, or one-piece zirconia abutment. The other one is called two-piece zirconia, or hybrid, or sometimes metal zirconia. I would like to repeat that. Make sure your lab technicians are using two-piece zirconia abutments with the metal base and not one-piece zirconia abutment. It's a known fact, and with the one-piece zirconia abutment, you're going to have the connection between the zirconia and the metal. Zirconia is going to be somehow abraded, and then you're going to have the fracture just like that. So extremely important. Make sure that your technician is going to use the one-piece zirconia, two-piece zirconia abutment instead of one. There is now if we are going to have a two-piece zirconia, so now we know that two-piece zirconia abutment is going to give us less complications, fractures. We're going to have less problems. So let's see what are the best options with the two-piece zirconia abutments. So how we can prevent the problems with two-piece, the better zirconia abutments. Al-Bahtani did a very interesting study. They had 3 different types of zirconia abutment with metal base. On one of them, they didn't touch the surface, so they centered it and that's it. They cemented the abutment to the base and everything was milled, everything was fine. With the second one, they started grinding about 1 millimeter from here to provide this sort of nice margins. And third one, they reduced that line about 1.5 millimeters, brought them down. So now you have 3 different types of abutments with different collar height: 2.7, 1.7, 1.2. Okay, and then they loaded those ones, and they checked what was the rate of mechanical failures. The results showed that the untouched two-piece abutments were considerably higher than the other two, and it has a very interesting message to us. If your technician is going to use the two-piece zirconia abutment, we need to know that the lingual, especially for the front one, we always use it for the front ones. You need to know that the lingual neck of the zirconia abutment is the weakest spot. So the technician does not need to grind anything, does not need to take away anything from the lingual side, just to make sure that we have enough thickness in that area. So layering the porcelain and the lingual is not going to serve anything. It's not going to give us a better view. It's not going to give us a better biological reaction. It only makes our zirconia weaker, and we have to make sure that, well, the technician is not reducing this area as much as possible. It has to be untouched with the thickest possible thickness in that area, in the lingual neck, which is the weak spot of our abutments. So to explain that, they said that, okay, number one thing is the stress concentration. Once they start cutting the abutment, there will be some irregularities and there will be some stress concentration spots. It can cause breakage, and of course the reduced bulk of the zirconia can cause the fracture. Now, is it high using the zirconia abutment? Is it a high risk in high risk cases? Are we going to have problems with them when the implants are placed in a shallow? So the emergence profile is quite short. The implant is shallow. And now we're going to use the zirconia abutment, but we have to know that if we are placing the zirconia abutment, the collar is small, so it's like a paradox. We need to place zirconia abutments where it's shallow to avoid, so we're going to avoid the aesthetic complications. But at the same time, in these cases, the size of the collar is going to be minimal. So I guess that's the only option that we have. However, in cases where you have a thick collar area at the lingual side, you are going to have a very predictable result. There shouldn't be any problem. And whenever you see that your abutment looks like this, with a very almost no shoulder, there is a better chance that it breaks. So if you are going to have a zirconia abutment, you have to make sure that the lingual color of the zirconia is not reduced as much as possible. So we have to make sure that the area on the margins are not going to be too much manipulated. That's the advantage of titanium. If you are grinding the margin, or your technician is grinding the margin in a titanium abutment, there won't be any problem. With the zirconia, you are going to have a problem, mostly because, well, of course, the stress concentration area is going to be there, and of course, we are going to take away some bulk of the zirconia. For that reason, prefabricated zirconia, at one time they were very popular, and they all broke, almost all of them broke. Prefabricated zirconia abutments are completely useless. There were cases that you had actually you have seen those or have those prefabricated zirconia abutments. The zirconia abutment was there, you would place it, you would start preparing those zirconia abutments. That was very cost effective, taking the impression abutment level, and then you would have the crown on them. But it's a very, very risky way to restore that, and you're going to have a high risk of fracture. Okay, so we talked about gold tube, and it's used in another context here. I want to talk about the contour of the restoration, and how much it can cause aesthetic complications. What we have to remember is that when we are placing our abutment in, if we are getting a lot of whitish view here, the blanching doesn't necessarily mean that it's a good, predictable way of restoring it. Mostly because when you have so much pressure on the soft tissue may react differently. There will be some sort of changes, and the soft tissue may shrink a little bit. So in most cases, I have done that. In most cases, you get quite a bit of this kind of whitish view, and whenever you get this, you have to be very careful. One of the best ways to avoid that is using temporary, just to register and record the emergence profile for our technicians, so they can actually know how much exactly they are expanding the tissue. It is mostly, the reason that this is happening is that your technician does not know how much he or she can expand the tissue. And because we have not developed the emergence profile beforehand, now the technician is relying on compressing the tissue, and this can cause the apical migration of the gingival zenith, and then of course the abutment is going to show, and that would be a big aesthetic complication. As you can see in these cases, well, as you can see that there's almost no irritation, no inflammation. It's not mucositis. It's not gingival mucositis or pre-implantitis, most probably. Tissue looks very healthy, and the only reason could be this very over-contoured. Can you see this? Very over-contoured area of CJ of the canine, or the same with this lateral. And usually the best way of developing a good emergence profile for the technicians is using a good provisional stage, and in most cases we don't have the luxury of doing that in private practice. It's very difficult to charge the patient for the temporary, leaving the patient on temporary for 6 months. I'm doing it day to day. I'm working both in private practice and in the school. I know that there are different expectations, and patients in many cases wouldn't accept that. But the truth is that when we are not taking those steps, there's a good chance that we have unpredictable results. I want you to take a look at this case that we had, and it's very interesting that the temporary was made with a bulky contour. So the bulky contour of the temporary was made, and after a while, the apical migration of the tissue was observed. To solve this problem, a combination of the gingival graft, gingival manipulation, and also recontouring the temporary abutment and temporary crown was done. And after a while, when the patient went through the healing period, then he had, and as you can see, the contour is much less prominent as compared to here, and the zenith came back. As you compare this to this, you can see that there is a big difference, and the temporary can make such a big difference. The other case that I had is my own is one of my own patients. Yes.
You go back to that previous one. How did you, like, there was an implant in there, you readed it, or?
Pardon me? Let me just go back. Okay. Okay.
So how did you correct that? And you just,
Pardon me?
how did you correct that? Just with the temporary?
So yeah, the temporary, the contour was very prominent here. So the contour was very prominent, causing the tissue to migrate apically. To solve this problem, a soft graft, gingival tissue graft was done in ORC and and also the contour was cut back, and the contour was made in a way that it wouldn't put too much pressure on the tissue. The tissue can actually sit against the contour of the temporary, and after a while the result was quite acceptable and nice. There is another case here that I did. Unfortunately, the first picture doesn't show, I don't know why. But the problem was that this one, this is a, Hamid probably know this case better because I have done that in a practice. He is involved too. This tooth is a prep. This tooth is a prep, and this is replace an implant. So the implant is healing at this point, and the patient. So I put the temporary. As you can see, it's not too bad, but you can see the pink architecture, which is not the greatest. And then after that, I asked the lab to make a good temporary with the wax up and everything. And as you can see here, I provided some space for the tissue to grow back. And I left the patient on this good temporary, which was essentially a duplicate of the final, for some time. The patient was with that for about 3 to 6 months, if I'm not mistaken. And then after that, the site was almost ready, and the tissue is coming back. The final was made, and then, as you can see here, the result is quite nice. And in this picture, you can see that it's completely healed. After about 6 months, I would expect that even this will be done after about a year or so. So a temporary can make it or break it, especially in these cases. You develop the emergence profile that you want, and then and then you capture that emergence profile you register that emergence profile for your technician, and now your technician can develop a nice prosthesis for you, and you can avoid the prosthetic complication and aesthetic complications that we may face if we don't do that. Okay, let's move on. The next one is related to the implant-supported full complete, as we call it, complete fixed dental prosthesis. The patient comes to your office with some sort of irritation here. The prosthesis is stable, it's not going anywhere, but you get some sort of tissue inflammation, and patient says that, well, I have this sort of pain. Anytime that I'm chewing, there is some sort of pain. Well, that's because of the tissue going between the components, between the abutment and the prosthesis. And now the patient chew on it, pain is going to be there. Either the screw is loose or fractured, most of the time easy fix, and then after a few months the irritation is going to go away. The same thing can be seen with the overdentures, with the bars. You get exactly the same thing, and that is the other problem that we face. Again, another picture that you can see here. The main reason is that in these cases you have this sort of flexure of the metal and the acrylic and also the screw. So small amount of opening will be between the abutment and the prosthesis, and the tissue can actually get caught between them, and the irritation is going to happen at the interface of the abutment and implant. Next is about the framework passivity. That is a very important thing again. As you can see in this picture, if the for some reason the arrows are a little bit lower, but here there is a little bit of space between the abutment and the implant, and it's mostly not because it's not completely seated, it's because it's not fitting properly. It's a one-piece splinted crown, so for that reason, although it's seated 100% here, it's open here, and you are going to have some space for bacterial plaque, and bone loss can happen. So that's a very important problem, and we're going to talk about that. Now, how to test if it is seated or not completely, especially for full mouth cases, for hybrid design prosthesis? Well, you're going to put the prosthesis in, and then you are going to start screwing in the first screw on one side, and when you tighten it all the way, you touch the other side, it's not going to move. So whenever you have a long span prosthesis, screw retain, make sure that you place the first screw on one side, and then touch the other side to see if there is any movement or not. There should not be any movement, even with one screw. And that will tell you if the framework is passive or not. The next step is, or the next level of knowing if your framework is passive or not, is when you are tightening the screw, it comes to a complete stop. It's not like getting tighter and tighter and tighter. It goes all the way and then boom, it stops. You don't feel the gradual tightening of the tissue. Now, there is a noise in this method, and that's the soft tissue. Sometimes the soft tissue is not going to let your screw all the way going down. So for implant level prosthesis, it's difficult to know if the abutment is tight with this system. Feeling if the screw tighten is getting tighter gradually or
all the way in 1 second, yes.
These screws, you don't torque them, right? You just hand tighten?
No, torque them to 15.
Or you just
Usually hand tightening is less than 15, and that's 15. These are 15, so it's better to go for 15. Yes, these are prosthetic screws. But as I said, using your tactile sensation to see if it's passive or not would work perfectly for these cases that you have the abutment, it's metal on metal. Tissue is not involved, but wherever you have the emergence profile, the abutment and the crown is going in, the tissue may actually resist. So you may not have that sort of sense that it's going in and then it stops. So you have to just be careful, and sometimes, of course, we will check our x-rays to see if it is completely seated or not, passively or not. Now, what are the consequences of lack of passivity? Well, number one thing, the main problem is that there may be a gap. Because it's not seated all the way or it's not passive, there is going to be a sub-millimeter or sometimes even less than that can be enough for bacteria to have a nice harbor. And we know that once you have the bacteria, you are going to have a problem. Second is the occlusal adjustment. You place the implant, you check the occlusion, it's completely off. It's 100% more than what you want. Patient is saying that it's just too high. It's mostly because it's not completely seated and it's not exactly the way that the technician designed it. And you end up ruining the anatomy feature. And of course, the internal stress will be inside the implant abutment prosthesis system. So you are tightening it, this stress is going to be transferred to the whole system. What's going to happen? Well, this stress is going to be transferred and something's got to give. You are going to have some issues with porcelain cracks and fractures. You are going to have screw loosening and screw fractures. And of course, the internal stress in the acrylic will cause acrylic craze. So in metal acrylic, you're going to have fractures in your acrylic. So non-passive prosthesis can cause a lot of a wide range of prosthetic and biological complications. Here I want to show one of the cases that I did in IPU. The case was back. It was actually one of the residence cases. And I inserted that. I felt that it's not passive. And this restoration was all porcelain metal. About 5 or 6 implants and then porcelain metal all the way. All of a sudden I heard the crack, and sure enough, all of the teeth were showing some sort of cracks here and there. The solution? Throw it away. That's it. It's not going to work. You are going to have a new impression, all attached in patient mouth with the verification jig. You pick it up, and then you send it to the lab. The lab is going to put this, cutting the metal, and then developing the right passive framework. So passivity of the framework is going to be a very important factor. We have to pay attention to it. And now in our department, in our Prostho department in UFT, we recall many of the patients who were restored in 80s when Branham was here. Recall, I had the opportunity to recall them and take a look at their prosthesis. And then we did digital imprint of the integral surface of those abutments and the itero registration of the abutment surface. I matched them together, and then we came up with it. So the software would give us the discrepancy between the framework and the abutments. And it was published last year, 30 patients, and there were some interesting results. Number one thing was that the recall time was 19 years, so it's quite considerable. And there were higher screw fractures in patients with higher level of misfit. There were higher rates of acrylic fractures. And interestingly, there was no effect on the bone loss. So although some of them were not as passive, but the bone loss was not an issue. There can be some explanations for that, including the effect of this prosthetic screw, which is the weak link, and it may not be transferring the forces to the bone. But in general, it was interesting that the misfit caused a lot of problems with the prosthetic issues, but no problem with the bone loss. Now let's go to kind of a controversial, is it controversial or not? Cantilever implant-supported fixed dental prosthesis. Is it possible? Can we have this sort of design without being afraid of bone loss? Because well, that's one of the issues, and it's been always talked about. To address this question, we have a very good study from Romeo. It's a prospective study, 7 year of follow-up, and as you know, nowadays you can find the studies for everything. And I have to say that many of the studies are plain lies, to be honest. So you have to be careful when you're looking at these studies. It has to be coming from a good research group. It has to have a lot of criteria. So it's very important to know which studies are more reliable. But in this study, 7 year prospective study, they realized that, well, after having the cantilever, one tooth cantilever bridge, the survival rate was good, and also there was no effect, there was no detrimental effect on the bone level of the pre-implant area. So they concluded that, well, cantilever for implants, no problem. Then after that, there were so many studies showing that, one after another, showing that cantilever is not going to cause any issue for the implant. And for that reason, Belser and Boozer from ITI group, they got bolder. They said that, okay, so now we know that if we have two implants, one cantilever would not be a problem. Many studies have shown that, evidence-based, do it, no problem. Now, what's going to happen if you have one implant and then one cantilever? It's quite bold. So Belser and Boozer, they're not little people. They know what they're doing, and they did this study, and 14 years of follow-up actually they had. It's retrospective, so it brings down the level of reliability to this study. But at the same time, it's still very interesting that even with single implant and then the cantilever, they had no problems with the bone loss. However, the rate of mechanical fractures such as screw loosening, screw fracture was higher. So whenever we have these sort of biomechanical issues, for sure we're going to have mechanical problems. But the biological part of that can be very, very gray. We don't know if it's going to happen or not. In many cases, it doesn't happen the way that we would expect theoretically. So, do I do single implant with cantilever? No, I wouldn't do that. I will wait for more studies, and I'm sure that there will be more studies. Yes?
Do they reduce the explosion on the cantilever part?
Yes, yeah, of course.
Yeah.
Otherwise, you're going to have a lot of screw fractures. So you have to be careful. Yeah, very good point. You have to be careful with the load that you're putting on the cantilever. But it's not comparable to the cantilever where we put on our abutment teeth. So that's different. Yes.
Was there any distinction between mesial and distal?
That was actually one of the very interesting that there was no difference. There was absolutely no difference between the mesial and distal. That was one of the objectives of the studies. They checked both mesial and distal, no difference between the two. You would feel, you would say that most probably the distal ones are going to have more mechanical problems, but no, they didn't show such a thing. Maybe the sample size was not big enough. Okay, so now let's go and have a conclusion on this topic, cantilever. Can we? Yes, we can. Definitely we can do. And that would provide, in many cases, would simplify the treatment. It will make the treatment more affordable for the patient, and in many cases it will avoid more complex, complicated, less predictable, huge grafting treatments, and we can take advantage of that. Okay, so let's go back to the Prostho route. Inaccurate impressions, they can cause complications. Open tray versus closed tray, that is important to know which one is better, when we can use which one. So in general, open tray transfers are more secure and stable, you know that. Mostly because, well, with the closed tray, which is inherently not accurate, we have to put back the transfer inside the impression. This will cause a distortion from the original position, can theoretically cause a distortion. So for that reason, we know that any kind of long span prosthesis can be a problem, the passivity can be a problem if you are using only closed tray impression transfers. However, I'm not one of those who would say that no, there is absolutely no room for closed trays and we always have to go for open tray. No, in many cases for single implants, there is no real clinically significant difference between the open tray versus closed tray. So for single implants, I would use closed trays. And in these cases, especially if the position of the implant is in a way that you don't have enough coronal part for the transfer, so the transfer cannot be placed properly, you may have, even in single implants, you can have some problems with the interproximal contacts, with the occlusal contact, mostly because when you are putting back the closed tray transfer inside the impression, if inside the impression the socket of the transfer is long enough, is tall enough, the grip will be better from the impression material, so it will be more stable. While when you are taking the impression, let's say that, for example, in this case, the head of the impression transfer is here, okay? When you take the impression and you want to put back the transfer, you will see that you have only from here to here this much space, which this much of the transfer will go inside the implant, and that will cause unstable condition for our transfer. So for any case where you can't have long enough closed tray, I would say that it's better to go for open tray. If it is one implant, two implants, whatever, if the head is here, don't do it. Because later, when you put back the transfer inside the impression, it's going to be very unstable. There's no studies in these sort of things. It's just a practical thing. And after a while, you get the sense of, well, it's better not to do that. So for that reason, especially when you have very deep implants, if the implant is very deep, then the transfer is going to go down quite a bit, and then the head is going to end up somewhere around here if you don't have the long transfers. Then your impression is not going to be very accurate. So in those cases, I would recommend going for open tray, even for single implants. Okay, now, of course, we always take the impression and take the X-ray, and if we see that the transfer is not seated completely, for any reason, if you miss that, of course, the occlusion is going to be completely off. The case will come back. You see that on the model, it sits nicely, the occlusion is good. You put the patient mouth, there's absolutely no contact. Well, in many cases, that doesn't make a huge problem, because, well, if it's not in contact, it's not a big deal. Usually it's better to be under load than overload. But once you see this, you will know that most probably the abutment, the impression point was not seated. Now that the abutment is going all the way down, with some problems with the emergence profile, putting so much pressure on the tissue, I had some problems. But now that it's all the way in, I'm not going to have a very good occlusal contact, and it's going to be somehow not in contact with the opposite. Now, one of the things that you have to make sure that you observe, especially for long span prosthesis, is that whenever you have the verification jig, you should put the verification jig in patient mouth separate. You have to make sure that it's cut, the verification jig. And then you attach the verification jig inside the patient mouth using GC pattern, or nowadays I use the Flogo. Attach them together in patient mouth. And then after that, do not send this verification jig to the lab. Pick up the impression with this verification jig now. That's the best possible impression that you can take. So verification jig in patient mouth, or attach in patient mouth, and now you pick up the impression, open tray impression. That's very accurate. It's going to be bang on. I have to say that I have never had any sort of problem with the passivity when I do this technique. So definitely very reliable. Now, in terms of the open tray, or when you connect all of the open trays, of course it's going to be more stable inside the patient mouth. The good thing about that is that you are not relying on the impression material at all. The impression material is just going to take an impression of the soft tissue. It has nothing to do with the impression of the implant. The impression of the implant is completely separate from the impression materials and the dimensional changes of the impression material. So that doesn't do any harm to your impression. So that's a very good way to do that, and you attach the copings to each other, and you can easily take good impressions. And the best thing about separating the verification jig is that now you're going to have a little material. The reason that we always make the verification jig and then we cut them and then we attach them in patient mouth is that any material that we use is going to have quite a bit of polymerization shrinkage. If we have the polymerization shrinkage, although the impression copings are attached in patient mouth inside the patient mouth, but there will be an internal stress because of that shrinkage. Now, once you remove that impression mouth, it's not going to stay like that. It's going to shrink. It's going to somehow get deformed. So for that reason, we always make small cuts and then inject the flowable one by one, polymerizing them separately. This way, the polymerization shrinkage is not going to be a factor, and our verification is going to be very accurate. The next practical factor that we have, the other complication that you may get is with the close to a impression copings. In most cases, the impression copings, close to impression copings, have this little spot for the screw. If you don't fill that spot for the screw, later when you take the impression, you want to put the impression coping inside the impression, is not going to be going 100% inside that impression material. So definitely your position is not going to be 100% accurate. Make sure that when you are using the closed tray impression coping, for sure use a piece of wax, a little piece of wax, you cover that screw axis, and then by doing that, there won't be any problem. Many companies have come up with some sort of either a plastic insert, so you don't have that hole anymore, or with the holes, for example, Straumann has come up with this sort of system that goes right in. It's not a little hole, so there won't be any problem. You can see the plastic insert here. Astra has made it in a way that there's absolutely no screw hole. It's all round. Sometimes it's annoying because you have to use your fingertip to do that. Other companies, again, as you can see, they put plastic insert. But in Nobel, for example, here, the hole is there. You have to make sure that you fill that hole with the wax. And also in Hyosin, as you can see, there's a big hole here, and it's not going to go in if you don't cover that spot with wax. So that will help, and that's a very important little issue that can cause some complications later. Now let's talk about the carotidized tissue. I know that it goes to the realm of periodontics, and I'm sure that Basil is going to talk about that a little bit more. But here, I need to mention this difference between implant and natural dentition in terms of the connection to the soft tissue around that. As you can see, the supracrustal fibers in natural dentition, natural tooth, are very tightly attached to the tooth with Sharpie fibers, and you have a very tight connection protecting the level of the bone. With implants, we usually don't have that. The fibers are vertical, not horizontal, and the connection is just very weak hemodisposal connection. And as you can see in this picture, you can see that, well, the vascularization is quite much more than the implant area. The connection of the fibers are different, so it's not sealed, and in many cases, you can say that the connection of the soft tissue to implant mechanically is weaker, and vascularization is less, of course. Biological barrier is not there. It's this basically no barrier protecting the level of the bone or the crust of the bone, and bacteria can go in much easier around the implant. And for that reason, pre-implant mucosa is much more susceptible when you compare it to the natural dentition when the bacterial plaque is going to form. So we have to keep this in mind, okay? Now, the next issue is that now if we don't have this tight connection, tight biological connection between the abutment and the tissue, what is the next available option? Well, the next available option is a thick carotidized tissue. Thick carotidized tissue can actually grab the abutment so tightly, providing some sort of barrier, so bacteria can penetrate less. That's why we always say that, well, carotidized tissue is so important. It's just a practical thing. It will provide a tighter connection between the soft tissue and the implant, and it will help with the health of the tissue, and of course, the amount of the injury of the tissue during function, during mastication is going to be less when you have carotidized tissue. It's going to be even worse in overdenture attachments, mostly because with this situation, removable prosthesis moving here and there, you get a lot of these things if you don't have carotidized tissue. So just remember that whenever you have an implant overdenture kind of attachment, make sure that you have a good carotidized tissue, level of carotidized tissue around your implant. For fixed cases, you need that less because it's not moving at all. So, as you can see here, it cannot, when you're probing, it goes all the way down, and there is a difference between natural dentition and the implant. So you have to make sure that you understand this weak, heavy desmosomal connection between the abutment and the tissue is not as good as the sharpie fibers. Now, it has a practical effect on cement retain versus screw retain. I just passed by this piece of history, which why cement retain became so popular before it was screw retain. Yes.
Is there a minimum number of carotidized tissue, like 2 millimeters?
Yeah, usually we say 2 millimeters. That's not good. That's correct. So, anyways, ITI brought that. I go through that quickly. Nobel responded with Cera 1, and then after 90s, cement retain became popular. Now, with the cement retain, well, you don't have any problem with the holes, so it looks better, aesthetically it's better. And the next one is that at the time you had the stock abutment, it was cheaper to make the, for some reason the pictures are not coming up here, I don't know why, but so screw loosening is less with the cement retain, so you have less mechanical problem, and also it has a better passivity when you're using the cement, so that's another advantage. And of course the manufacturers were pushing for cement retain. For that reason, through the 90s, you had quite a bit of cement retain trends going on. Now, when you look at that, you will see that, well, with the cement retain, you have this advantage. Much more convenient, prettier, less screw loosening, all these sort of advantages. But, and it's a very big but, that you have to remember. Don't get me wrong, it's Peter Griffin. You have to remember that there's a big disadvantage here. Cementation of an implant-supported restoration can be very tricky, very tricky. Even the most experienced clinicians can have a problem, complication for that. And the reason is that there is no connection, as I said. So you don't have any nice connection barrier here, and you have the hydraulic pressure of the viscous Cement, usually we say that we'll use temporary cement. It's very viscous. So the hydraulic pressure is going to put the pressure all the way where? Here, and it goes all the way in. So that can cause a very important biological complication. And as you can see in these cases, the implant was placed, you get the inflammation, you do the exploratory surgery, look what is there. And of course, you can see that the cement went down all the way. Another case, a lot of cement here, well, look at this one, it's almost gone. Then the next one is how to avoid that. One of the easiest way, probably you have heard about that. You can simply use the biotype material, a Q-tip. So you inject the biotype material inside your crown. You put a Q-tip inside it, and then all of a sudden you have a duplicate of your abutment. And before cementing your crown, you're going to put the cement inside the crown, put the duplicate abutment inside it, the excess cement is going to go away, and now you can place the crown in. That will help quite a bit with the cementation. Now, I guess I'm running out of time, I think. I would like to continue with the complications, but unfortunately there's no time. I'm pretty sure that you're tired of my building material. I hope that you liked the presentation, and during the break time I'll be available if you have any questions. I'll be more than happy to answer your questions. Thank you.
Thank you, Shokati.